Hello, this video is a small portion of a complete comprehensive video. If you'd like to see this complete comprehensive case and many other complete comprehensive cases, click on the link in the description below. Okay, so we're first going to place topical anesthesia, the patient's sedated. Watch this video on how to give painless and profound mandibular anesthesia, and watch the other video on how to give painless and profound maxillary local anesthesia. That's very important. Now, I'd start and I'm placing a dot. So how far from this tooth would you ideally like the center of the implant? In a perfect world, you think how wide is a molar tooth? Probably 7-8 millimeters. So you'd like this in a perfect world about 4 millimeters from this tooth. This is a little bit further distally. Then I'm going to place a second implant there. So I've first wiped the tissue with chlorhexidine on a cotton ball. Be sure everything's clean. So I'm measuring from the alveolar crest to the superior part of the inferior alveolar nerve, and that's approximately 14 millimeters. With the dentist drills, the longest drill from the tip of the drill to the shoulder is 14, and that's plenty of depth. You know, what if you go to 18? Well, is an 18 millimeter implant in a case like this more stable than a 14? No. So I'm probably going to use a 10 or a 12. So this is at 12 millimeters. This is the pilot drill at 12. I know that's a safe depth. So this is the dentist system, and every one of these drills has a shoulder on it. So you can see this is an 8 millimeter long drill all the way across, a 10 millimeter long drill all the way across from tip of drill to shoulder, 12 and 14. You'll start with the pilot drill with the endo stop on it at a safe depth. This is going to be the depth, the maximum depth of the implant, and this is going to be the width of the implant. So since these are molar teeth, the width of the drill in this case would be 4.8. The width of the drill in this one, 4.3, 4.1, 3.7. You want the implant to be a little bit wider than the drill. If it's in the mandibular anterior, that's really hard bone. So you probably only want the implant to be a few millimeters wider, millimeter 2 or 3 wider than the drill. So if you were using a 4.8 millimeter drill, what do you want the implant to be? Maybe a 5.0 or a 5.2. You want the implant to be only 2 to 3/10 of a millimeter wider. I may have said millimeter a while ago. You only want it to be 2 or 3/10 of a millimeter wider than the drill. All right, now think about this. So this is approximately 14. This is not the height of gingiva. There's the height of gingiva. This is from alveolar crest to the superior part of the inferior alveolar nerve. And that's about 14 from top of bone to superior part of inferior alveolar nerve. Now you've got 2 millimeters of soft tissue here. So you've got a good solid 14 millimeters from gingival, from height of gingiva to the tip of the implant. Now we'll go back to this. So I'm measuring safely. You know, this tip is is about 13. This measurement of the endo stop to the tip of the pilot drill is from the crest of the gingiva, not the bone. So you've got to add 2 millimeters to that measured height. So I've got a good solid 14 millimeters. This is safe. The idea is you want to be at least 2 millimeters in a perfect world from the superior part of the inferior alveolar nerve. So I've had to add 2 millimeters of gingival height to the measurement from the alveolar crest to the superior part of the inferior alveolar nerve. Think about that. So bone is 13.85, add 2 millimeters. That's 15.85, that's 16. So I'm safe drilling to 14 millimeters because a periapical radiograph is 1:1. Now you could not measure that on a pantograph. If you want to be triple safe, you could have a cone beam and you could use a pilot drill. Now why am I teaching this system? Number one, I like it, and many of you are not in the United States, or you're in a rural area or someplace that doesn't have a cone beam. So how can you place implants predictably without a cone beam radiograph? Like this. Like this. You don't need a cone beam if you use this system. So you want this endostop to be stable. See, I'm going to drill, and what I want the tooth in front of it to see that this implant, this cone beam is approximately parallel to the tooth in front. Now when I place both these implants, you'll see that they're not quite parallel to each other. They're close, and this implant is a little distal to this tooth than ideal, but it works really well. This is real practice. So we decided to go with a 12 because that's plenty of bone. I know I'm safe. I'm probably going to be 4 millimeters from the inferior alveolar nerve. 12 millimeter implant in the posterior is plenty of stability. Okay, so here we go. We're going with, I would like the osteotomy to be a little bit deeper than the implant, because that implant's not going to screw any deeper than the osteotomy depth. So I don't mind the osteotomy being a little bit deeper than the implant. So this is a little wider pilot drill, okay? So that's 12.1 tip to top of alveolar crest, and we've got 2 more millimeters up here. So if this is 12 from here to here, what size drill am I going to use? A 14. 12 in the bone and 2 more in the tissue, because that shoulder of the drill is going to stop when it contacts the gingiva. So 12 is plenty. So I've placed one of these parallel pins, so you can see I've drilled this, I've begun this hole, this osteotomy. Now I'm going to drill the osteotomy behind it and put this parallel pin in whichever hole osteotomy I drilled first. So I put this one in. It's not complete, it's just begun. It's wide enough to hold this parallel pin. I'm going to use that as a guide, and I'd like to be about 7 to 8 millimeters distal to this. See, I want to be about, you think both the second molar and the first molar, if you measure from the center of the tooth to the distal of the tooth to the center of the tooth to the mesial of the tooth, that's going to be about 3 to 4 millimeters on each one. So you want the distance from this osteotomy to the center of this osteotomy to be what? About 7 to 8 millimeters. So we've decided to use 12 to be very clear of the inferior alveolar nerve, and that was plenty. So this is a wider pilot drill. Okay, now remember, this osteotomy is in the bone, but there's also 2 millimeters of soft tissue. So a 14 millimeter depth is going to give you 2 millimeters of tissue, and it's going to give you 12 millimeters of implant in the bone. So I'm checking these to be sure they're parallel. You can see this is just a little bit off, and so as I go through my progression of drills, I'm going to angle it just a little bit distal. So that's 10.22 in the bone. If I'm using a 12 millimeter, see, 12 millimeter distance from the bottom of the endostop to the tip of the drill includes 2 millimeters in the soft tissue of gingival tissue and 10 millimeters in the bone. So I'm very clear of the inferior alveolar nerve and have lots of stability with the osseointegration of a 10 millimeters of implant in the bone. So the final implant is going to be about 10 or 10.5. So now we're going to progress through these drills and see the shoulder on the drill. I love that, and for the life of me, I have no idea why other implant companies don't use that shoulder. Because if you've just got markings like this on the drill, you're having to watch them, and every drill you've got to watch them as the drills get wider and be sure you don't go too deep. With this system, once you establish your depth, you don't have to think about it anymore, because every drill has got that shoulder at the right depth. Duh. What's going on here? Why would they all not be that way? So I'm going to go toggle back and forth, keeping something in the adjacent osteotomy as I widen the other osteotomy, just to keep the implants approximately parallel. I don't care if they're perfectly parallel. I want them to be approximately parallel. See, so you can put some pretty good pressure on the soft tissue, and the drill, this is the drill, and this is the osteotomy in front of it. And as you drill the osteotomies, you can see what the parallelism is of the two drills, and you can change it as you widen the osteotomy. See, so these are a little bit this way, that would work fine, but as I drill this osteotomy, I'm going to move it back just a little bit and change the angulation, which is easy to do because each drill is progressively wider. See, I'm pushing distally on that drill just to parallel it. I want to go all the way and have so again, checking the parallelism of them and keep moving. I'm switching, paralleling this piece into the other osteotomy. So I've always got something to mark that, so I'm keeping them basically parallel to each other as much as I can. See, that's pretty parallel. I'm going to the next one now. I'm at 3.7. Put the paralleling piece back in this osteotomy. You know, working in the mouth, especially in the posterior part, if you don't have something to keep you parallel, you could get lost because you're not looking at a perfect angle. So these are very helpful. And then once I get going, and I've taken a periapical radiographs at the beginning, I normally take another periapical radiograph every 2 drills just to be sure I'm staying about in the proper alignment. And you can see how now you can go pretty quickly. That drill just drops into the osteotomy and is stopped on the soft tissue by the shoulder. Makes it very quick, very easy. You can put some good pressure on the tissue because the tissue is going to stop the shoulder. So now I'm up to a 4.1 drill. I've got 2 drills in here now to measure. Here we go. They were pretty parallel. I've got the paralleling instrument in here, piece in here, and then I'm drilling behind. So now I'm up to a 4.3 millimeter drill, wide drill. Always keeping the paralleling device in there, or paralleling piece. See, so now I'm just leaving the drill in there so I can see that they're pretty parallel. So you see we used a 4.3 drill to go with this implant size, which is a little wider than the drill. And this is a 4.6 millimeter times 10.5 millimeter implant. So the osteotomy was 12 millimeters in the bone. So I've got about 1.5 millimeters of space, which is fine. That'll heal once the implant's in, it'll grow in. But this gives me plenty of space between the superior part of the inferior alveolar nerve and plenty of implant in the bone. That's the Dental Minute. These techniques work, and they work every time.
Are you ready to take your dentistry practice to the highest level possible? Of course you are! Subscribe right now to dentistrymasterclasses.com, where you will get Dr. Cutbirth's greatest work and best cases. Here's what you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos. You will get an organized library of all the Dental Minute videos and Dentistry Masterclasses, comprehensive cases for study and reference, before and after photos of Dr. Cutbirth's fantastic restored cases. And all of this, I repeat, all of this is just $40 a month. This is something you cannot pass up. Subscribe right now to dentistrymasterclasses.com.